Code Blue and intubation updates and instructions for potential COVID patients. Updates and reasoning. With the potential of COVID-19 positive patients increasing, HMH has updated our infection control guidelines for Code Blue and intubation of all patients. These guidelines are within the recommendations and some above with the current CDC guidelines regarding aerosolizing procedures. When entering the room, ensure staff that are entering the room of any potential COVID-19 patient have the proper PPE in place. Current guidelines includes the N95 mask, eye protection, gown, and gloves. We need to decrease the number of staff that are entering our codes and intubations and delegate those staff roles. When entering a Code Blue of a potential COVID patient, the primary or initial nurse will begin compressions. Do not bag valve mask or ambu bag the patient, as this increases the aerosolizing potential of the patient and potential for contamination. You may passively pre-oxygenate the patient with a non-rebreather mask on the patient with the oxygen at 15 liters per minute. Staff responding to enter the room will be decreased to 5 staff in the room. This will include the provider, the primary nurse for history and compressions, the secondary nurse, which is a code team nurse, 1 respiratory therapist, and a second code team nurse for inpatient or in-house codes, and an ED tech in the emergency department. Outside of the room is where the code cart must remain. The code cart remains at the doorway outside of the room to prevent contamination. The defibrillator can be moved into the room. A third nurse wearing surgical mask is to remain outside of the room at the doorway to be able to hand in medications from the cart, to keep a clean cart, and to document the code. A second respiratory therapist, also wearing a surgical mask, is to remain outside of the room to get the ventilator, run ABGs, and any other needs for respiratory. The responding pharmacist will also remain outside of the room in a surgical mask as well. Other pearls. A plastic barrier will be placed over the patient torso and head, draping over the head. You will see this in the video in just a moment. All potential COVID patient intubations will utilize the glide scope for intubation procedures. Do not use the colorimetric end-tidal confirmation, the normal easy cap. That will not be used for our COVID patient intubations. All patients will in turn have the waveform end-tidal CO2 inline connection placed on their ET tube. Preferred process is to place the patient directly onto the ventilator. However, if the vent is not immediately available, a viral filter will be added to the end-tidal CO2 connector and connected to the ambu bag for bag valve ventilation. Demonstration of the process. Non-rebreather mask can be placed at 15 liters and placed on the patient for pre-oxygenation while you gather all equipment. We will not be utilizing a bag valve mask for this patient, as that increases the aerosol in the air. We will go ahead and place a viral filter onto the ambu bag in case we do need it. Gather all equipment. We will use the waveform capnography, but not the easy cap, not the end-tidal CO2 colorimetric capnography. This shows our plastic barrier that we will be using. It is placed over the patient's torso, head, and neck, draping past their head, and all intubation procedures will be completed underneath the barrier. As you see, this barrier is perfect for decreasing the potential for any aerosol to escape above the barrier to the staff that are performing the intubation. Upon intubation, as we see through the glide scope, you'll remove the glide scope. The end-tidal CO2 connection will be placed against the ET tube, between the ET tube and the viral filter on the ambu bag if needed for ventilation. Again, best practice will be ET tube to end-tidal CO2 waveform connector directly to vent. At completion, we will roll the plastic barrier back towards the patient so that contamination stays away from staff, and continue to either bag or have the patient ventilated using our vent. Again, respiratory will be also taping all connections. Post-intubation, like I said, respiratory is going to silk tape all vent connections per CDC guidelines. We will provide normal ACLS procedures for the patient. But before moving the patient to a higher level of care, there are a few steps that must be completed. Wipe down the bed and any movable equipment. This is the outside of the bed. The patient does not have to be moved off of the bed. Wipe down all parts of the bed, our ventilator, our IV pumps, and any other movable equipment. You will then remove your contaminated PPE, don new PPE before taking the patient into the hallway, and staff transporting this patient will wear a surgical mask, gown, and gloves. You see, it is no longer recommended for the N95 as all is contained within the viral filter or the vent. Remember to clean the glide scope as soon as possible to have it ready for the next intubation need. Patients then transported to their area. In summary, staff in the room needs to be decreased, and all must be in the current N95 gown, glove, and eye protection guidelines. The defib is allowed in the room, but the cart remains at the doorway outside of the room. You must have a clean cart nurse and documentation nurse, as well as a clean respiratory therapist outside of the room, both in surgical masks. Do not ambu mask ventilate the patient prior to intubation. You may utilize a non-rebreather for pre-oxygenation. The plastic barriers to be used during all intubation procedures until all the connections are complete. We then roll the barrier in towards the patient to keep contamination away from staff and discard. Waveform end-tidal CO2 capnography is used for intubation confirmation. Do not use the colorimetric EasyCap. And place the patient directly on the ventilator if possible. If not, we must utilize the extra viral filter between the patient, the end-tidal CO2 inline connection, and the ambu bag. This is all to protect us as much as possible. Thank you.